Urology exit exam discussions, we are going to discuss some scenarios on bladder cancer. The first scenario starts now and time is on now. You have a 55-year-old lady presented to GP with history of visible blood in the urine, and the GP has referred you the patient. What are all the 2-week criteria by which a patient can be referred to urology? You can explain everything, including prostate, penile, everything.
The referral criteria, the referrals to urology are as follows. So for suspected bladder cancer and renal cancer, it's patients over the age of 45 who have visible hematuria that persists after a UTI is treated or unexplained visible hematuria. And for patients over the age of 60, it's those who have non-visible hematuria and either dysuria or an elevated serum white blood cell count. For prostate cancer, it's men between the age of 50 to 69 who have an elevated PSA of above 3.0 nanograms per nanograms per liter, or who have an abnormal feeling and digital rectal examination. For testicular cancer, it is men who have a non-painful enlargement in the body of their testes. And for penile cancer, it's the presence of a penile lesion which does not respond to topical steroids or where there is a penile mass present.
Okay, so this lady is 55-year-old, referred for visible hematuria. How are you going to evaluate her?
So I'll evaluate this patient in a dedicated one-stop hematuria clinic with the facility to perform a urine dipstick, a urinary tract ultrasound, take history, perform physical examination, and perform an on-day Flexor Cystoscopy. In the history, I will confirm the degree of hematuria with her, the number of episodes, any associated pain, LUTs, systemic symptoms, and dysuria, as well as any febrile rigors. I will establish her past medical and surgical history and fitness for surgery, as well as whether she's on any anticoagulant or antiplatelet medications. I'll establish if there's a family history of urological cancer, and I'll also ascertain her smoking and occupational history. I'll then obtain written consent for her to undergo a Flexor Cystoscopy, and that will include at the same time a chaperone physical examination of the abdomen to elicit any loin or abdominal tendinous or palpable masses, and also an internal vaginal examination to elicit any palpable masses.
Okay, what is your imaging protocol for visible and non-visible hematuria?
For visible hematuria, I will follow. I will request a CTogram for all patients above the age of 40 who present with visible hematuria, and I'm following the guidelines of the Royal College of Radiologists. For patients under the age of 40, the Royal College I refer guidelines recommend that where there is visible hematuria, a CTogram be performed where initial investigations in the form of Flexor Cystoscopy and ultrasound are normal. Where it is non-visible hematuria, it recommends that CT is helpful where cytology is abnormal and where the patient has a previous history of transitional cell carcinoma.
Okay. This patient, you are doing flexible cystoscopy. Is there any specialized methods available for flexible cystoscopy to increase your sensitivity?
So for Flexor Cystoscopy, there is the use of white light cystoscopy and also narrowband imaging.
Could you explain the narrowband imaging?
Sorry, I can't recall.
Okay. Is there any other types of specialized cystoscopy available?
There is also photodynamic diagnosis, which is often performed at the time of general anesthetic rigid cystoscopy. This depends upon the intracycle installation of 5-amino levulinic acid, approximately an hour before the procedure, with one of its metabolite protoporphyrin being taken up preferentially by malignant cells. At the time of cystoscopy, blue light is then applied at a wavelength of 375 to 440 nanometers, and cells which take up the protoporphyrin will appear pink or red under blue light. The biopsies must be taken using white light, however, and this method has shown to have increased sensitivity in the detection of CIS.
Okay. So you are doing white light cystoscopy flexible for her, which shows a 3 centimeter lesion in the right lateral wall, not involving both the ureteric orifice. What is your next steps?
I'll see the patient after Flexor Cystoscopy with a urology cancer nurse specialist present, and I'll counsel her about the new findings representing a suspicion of a new bladder cancer. I will counsel her about undergoing a transurethral resection of bladder tumour with the aid of a Barrett's procedure-specific patient information leaflet, plus or minus a single post-operative installation of intravesical Mitomycin. I will arrange further investigations with measurements of baseline full blood count and urea electrolytes, and I will also arrange a CT urogram to take place preoperatively.
Okay, what is the role of cytology in this patient?
So according to the NICE guidelines, urine cytology is recommended as one of the potential adjuncts that should be used at the time of TURBT. The other adjuncts would include the measurements of urinary biomarker, such as Eurovision, Immunocyte, or NMP22. And the other adjuncts include Narrowband Imaging or photodynamic diagnosis. So cytology would have a role as an adjunct.
Could you explain one of the other urinary biomarkers, maybe one?
So there is Eurovision, which uses fluorescent in situ hybridization, and it detects extra copies of chromosomes 3, 7, and 17, and loss of the 9p21 locus. It has a reported high sensitivity than urine cytology, but a lower specificity.
Okay. So this patient is listed for TURBT. After appropriately consenting the patient, you are doing TURBT. What is your predominant criteria in TURBT? How are you going to complete the procedure?
So I'd ensure the patient is appropriately prepped, consented, and anaesthetised with a WHO checklist performed to include VT and antibiotic prophylaxis. I'll place the patient into a lithotomy position, prep and drape the area. I'll first perform an examination under anaesthetic to assess for the presence of any palpable bladder masses on biomanual examination and whether it's fixed or mobile. I'll perform a careful cystourethropy with a size 22 French resectoscope. I'll then identify the tumour, and I will perform a resection, loop resection using monopolar dithermy and glycine, starting off with resection of the exophytic portions of the tumour first, and then moving on to resect down to the base. I'll evacuate the chippings using an evacuator. I'll take a separate biopsy of the base and send this using a cold coat biopsy forceps and send this in a separate pot. I will ensure meticulous hemostasis using a Rowley-Ball dithermy, starting off with the centre of the base and then moving on to the edges. And at the end of the procedure, I'll terminate this by inserting a size 22 three-way catheter with continuous irrigation running. In my operative notes, I will specifically document the number of tumours, the size of the largest one, the superficial appearances, so whether it's papillary or solid, suspicion for presence of CIS.
Okay, we can stop there, Piyush. Well done. No major concerns, nice flow, nice communication. Maybe you yourself can identify a few areas, like, for example, narrowband imaging. And I mean, it happens, and what you have done is perfect. Whenever there is a hiccup like that, just say, I'm not sure, I can't recall, which is a better word than I don't know. And if you say, I'm sorry, I can't recall, then the examiner will go to the next question. And as you see, by the time the end of the scenario, the examiner may not even remember how once or twice if you have said, I can't recall, that doesn't matter. And go through that nice criterias for referral for 2-week pathway. You're fine. There is a slight deviation. Say, for example, for prostate cancer, they will also mention about the age-specific PSA, and also patients presenting with systemic symptoms which may be due to prostate metastasis like bone pain. A few areas you slightly deviated. Overall, it's fine. Otherwise, box standard, no major things, standard questions. I'm quite happy to go for next scenario, unless if you have any questions.
No, I think when it comes to talking about the steps of TURBT, because I wanted to get the checklist in at the end. Should I have done that, or was I right to try and include those points?
No, this is fine. I don't think that you have not reached the end of the scenario, because it could be either way. For example, this could be a scenario of evaluation of visible hematuria. Since you have done Flexor Cystoscopy, urinary biomarkers, imaging, cytology, everything, and there is a last minute, the examiner may have taken you to TURBT for completion. So it could be either way. So don't be in a rushed out to go to the end of the scenario at any time. Give a very standard answer, because it can result sometimes in your answers to be a little bit suboptimal. You may not bring out everything what you know because of urgency to finish the scenario. So in your aim is to bring out whatever you have in a very bullet point manner, rather than completing the full sentences. For example, for the question of what you will concentrate on TURBT, you can say, my predominant aim in TURBT is using Bow's consent, appropriate anesthesia preparation, like that, like bullet points, rather than I will do a Bow's consent, I will make sure that patient has anesthesia pre-op done, I will make sure that hemostasis is clear. Instead of that, make it like good hemostasis using rolly ball, making sure the pots are appropriately labeled as superficial and deep, like take it like that. And so don't get disheartened thinking that you have to finish up to mitomycin, etc. It could be just because it's a visible hematuria scenario and you maybe already crossed it. Okay, so either way it's possible.
Yes.
Good. Happy for another one?
Yes, please.
Okay, your time starts now. Let us continue with the same scenario. You have completed the TURBT. You are able to resect the complete bladder tumor. Superficial and deep biopsy specimens were taken and appropriate hemostasis attained. What is the role for immediate mitomycin? What is the evidence behind it?
The evidence for this comes from a meta-analysis by Sylvester, which demonstrated that a single postoperative dose of mitomycin produced a relative risk reduction of 39% in reducing recurrence, and an absolute risk reduction of 12%, with a number needed to treat of 8.5. And the same author then did a further meta-analysis in 2016, where these figures were 35% for relative risk reduction, and 14% for absolute risk reduction, and 7 for the number needed to treat in order to prevent one recurrence.
Okay, so how are you going to give mitomycin?
So I'll administer mitomycin at the very end of the TURBT, with 40 milligrams mixed up in 40 mils of normal saline. I will administer it via a catheter tip syringe attached to a flip flow valve. I'll administer it into the bladder, clamp off the flip flow valve, attach it to a specific catheter bag, and clearly document the time at which it was administered and the time at which it is to be released 1 hour later.
Okay, and the patient's histology is G2, high grade, PTA, TCC of the bladder, unfortunately no muscle included. How are you going to proceed further?
I'll discuss this patient at the urology MDT, and I'll also ensure that her CT urogram has been completed. This places her into the intermediate risk category as per the NICE guidelines on bladder cancer. And I'll therefore recommend that I see her in clinic with the urology cancer nurse specialist and offer her a course of 6 doses of intravesical mitomycin.
Okay, no muscle noted in the specimen. Will it change your steps?
So given that this is a PTA tumor, it does not, and by the NICE criteria, it does not strictly recommend offering a re-resection, but she'll require a check Flexor Cystoscopy 3 months after the course of mitomycin.
Okay, so how will you institute the mitomycin maintenance course? Is there any evidence behind it?
I'm sorry, I can't recall.
Okay, so you are giving 6 weeks of mitomycin followed by check cystoscopy. Check cystoscopy shows a recurrence in the same area of previous resection, and you are going for a re-resection under GA. The histology of re-resection under GA results as G3 PT1 TCC of the bladder. What is your next steps?
And can I confirm that there's muscle present in the specimen as well?
Yes, second time the muscle is present, not involved.
So I'll discuss this patient again at the MDT. This is evidence of disease progression. And the available options include offering this patient a course of intravesical BCG, further endoscopic management, or even offering her a radical cystectomy. I'll recommend that she be offered intravesical BCG.
Okay, take me through the evidence behind the BCG. How are you going to schedule her?
So the main evidence for BCG comes from Sylvester meta-analysis demonstrating that BCG, in terms of progression of non-muscle invasive bladder cancer, provided a relative risk reduction of 27% and an absolute risk reduction of 4%. In terms of the regime, I will schedule her as per LAM's regime, which essentially includes a total of 27 doses for up to 3 years. There is an initial induction course of 6 doses on a weekly basis, followed by I'll schedule a check rigid cystoscopy and general anesthetic for 6 weeks after that. And if this shows evidence of response to the BCG, then I'll schedule her for further maintenance BCG consisting of 3 doses over 3 weeks at 3, 6, 12, 18, 24, 30 and 36 months with a check flexible cystoscopy schedule of checking every 3 months for the first 2 years, then every 6 months for the next 2 years, and then on an annual basis thereafter.
Okay. How will you categorize BCG failures?
I categorise these as per the International Bladder Cancer Group consensus from 2016. BCG resistance is when there is persistent disease after induction BCG, but it's of a lesser grade and stage, and there is no longer disease present at 6 months. BCG refractory is the persistence of high-grade disease at 6 months, which includes progression, grade, and stage. There is BCG intolerance when a patient is unable to receive inadequate BCG and has persistent high-grade disease due to side effects. And then there is BCG unresponsive, which encompasses BCG refractory and BCG relapsing patients where they have recurrent high-grade disease within 6 months. And this is the subset of patients with the highest risk of recurrence and progression and for whom further BCG is not feasible. And there is also BCG relapse as well, which is the recurrence of high-grade disease after achieving a disease-free status at 6 months.
Okay. This patient is tolerating the initial BCG course. After first maintenance, when she had a cystoscopy, she had suspicious red lesions around the previous scar. Hence, she underwent rigid cystoscopy and biopsy, which showed CAS. Will it change your course of BCG or any treatment?
So in terms of further treatment management options we discussed at the NDT, these would include offering re-induction BCG, so with a further induction course, or again offering her a radical cystectomy.
What is CAS?
This is a flat, non-invasive but high-grade urothelial carcinoma.
Why it is important? Why we need to think up to the level of radical cystectomy for CAS?
The reason for this is because if untreated, up to 55% of CIS can progress to muscle-invasive bladder cancer. And in those who are administered BCG, in those who do not initially respond to BCG, 66 will progress to muscle-invasive bladder cancer.
What is BCG? How BCG is supplied? What is the dose?
So BCG stands for Bacille calmette-guerin. It is a modified form of the Mycobacterium bovis vaccine. The dose, the lowest effective dose is 27 milligrams, and it is administered intravesically.
Okay. If the BCG is not tolerated by a patient, do you have any other options?
So the other options could include offering heated intravesical chemotherapy. Interferon alpha is also another possible option with a dose of 50 megaunits, although that's not recommended in the current NICE guidelines. And further management options would then include offering radical cystectomy or continued endoscopic treatment, but with a high likelihood of further recurrence and progression.
How this heated mitomycin works?
So heated mitomycin works through incorporating itself into the tumor DNA as an anti-tumor antibiotic and preventing its separation, the DNA separation. But sorry, I can't recall any other mechanisms of action.
Okay. Do you aware of electromotive therapy?
I'm sorry, I'm not aware of that.
Okay. Both are almost similar. What about... Okay, we'll stop there. My next question is to discuss a little bit about interferon. And these are all quite nice high-level questions to give you that boost-up marks. And so go through about this hyperthermic mitomycin and electromotive mitomycin. Both are slightly different. In electromotive mitomycin, we are using the electric current to increase the penetration and the susceptibility of the bladder wall to the mitomycin, while in hyperthermic, it's just the heat temperature which is maintained, and the catheter is a specialized catheter. In the tip, there is a sensor to measure the temperature inside the bladder so that the temperature is appropriately maintained but not overheated to create a bladder mucosal injury. Available only in selective centers, so sometimes patient needs to travel a lot to get the services. And no major concerns again, nice flow. The only thing is, if you can recall or revise that video once it is available, if you see it's G10 to high grade PTA, if the muscle is not there, it is preferable to do early RT or BT. Only for G1 and G2 low grade PTA, and that too for small lesions like less than 1 centimeter lesion. If the muscle is not there, we can take it for granted that the chances of the muscle invasion is very remote, and we can treat the patient with if you see the patient who needs mitomycin, they will definitely need a RT or BT if muscle is not there. Only for patients like, as I said, G1, which is not reported now, G2 low grade PTA, where you are just planning for a 3-month flexible cystoscopy, those patients, if the muscle is not included, we can hold on if it is a small tumor. Your patient is G2 high grade, and also the tumor is 2.5, almost reaching 3 centimeters. So those patients, better to do RT or BT. Chances of muscle invasion is there, even though it's low. You can play it by 2 methods. You can say I will go for RT or BT in 6 weeks because of G2 high grade and also size of the tumor, or you can say I will give a mitomycin course because you need to treat the patient quickly. You don't want the patient to progress, but the first cystoscopy I will do under GA so that I can do some cold cup biopsies and get some adequate muscles. Both ways it's okay. Okay?
Yep.
Good. Can we go for another one?
Yeah, go for it.
Good. Your time starts now. You are lower track oncology specialist doing bladder cancers and prostate cancers in your unit. One of your colleague has seen a bladder cancer patient, evaluated, did TURBT. The result is G3 PT2 high grade bladder TCC in the histology. Being a lower track oncology specialist, you are taking over her care. How are you going to take it further?
I'd ensure that this patient has been discussed in the urology MDT with full staging scans completed in the form of a contrast-enhanced CT scan of the thorax, abdomen and pelvis. I'll also need to assess her comorbidities and obtain the recommendations from MDT. And provided she has no metastatic disease, then the treatment options would be to offer her a radical cystectomy, bilateral pelvic lymphadenectomy, and urinary diversion, or radical radiotherapy, and both of those as neoadjuvant chemotherapy. I'll then see her in clinic myself with a urology cancer nurse specialist and confirm her age, her history, her comorbidities and her general fitness for surgery, including whether she's on any anticoagulants, and also whether she has a smoking history. I'll then perform a chaperone physical examination to note her BMI. I'll examine the abdomen, looking to elicit any abdominal loin pain or tenderness or any previous surgical scars, and I'll also perform an internal vaginal examination to evaluate for the presence of any palpable masses.
Okay. How are you going to stage her?
I'll stage her. So she's already been staged histologically, and I will stage her for the presence of distant metastases with a contrast-enhanced CT scan of the thorax, abdomen, and pelvis.
Okay. Let us assume she has no lymph nodes or any chest involvement. What is the role for neoadjuvant chemotherapy if she opts for surgery?
So according to the ABC meta-analysis, adjuvant chemotherapy with either gemcitabine and cisplatin-based chemotherapy or with the MVAC regime produced an absolute improvement in overall 5-year survival of 5%.
Okay. And what is your next steps? Let us assume you refer the patient for neoadjuvant chemotherapy. After the chemotherapy, what is your next steps?
So my next step will be to repeat her staging CT scan and see if there's a response of the tumour to this, but also to ensure that she is not developed any metastatic disease. And in terms of next steps, I will then counsel her about the procedure if I've not done so before, and talk to her about the benefits, risks, and complications and post-op care of undergoing a radical cystectomy. If she, yes, that's what I'll do.
Okay, so how are you going to plan the radical cystectomy?
So I will ensure that she has a baseline blood test taken with a pre-op assessment to include a full blood count, urea and electrolytes, a group and save with a cross-match of 2 units on the day, and also taking preoperative MRSA swabs, an MSU and a COVID swab. I will ensure she has up-to-date imaging, and I will also ensure that she's seen by a stoma nurse if the plan is for a urinary conduit formation, and to go through with the patient how to live with the stoma and manage the stoma bag.
Okay, so what is your plan? After radical cystectomy, how are you going to reconstruct the ureter?
The preferred means of reconstructing the ureter would be with means of performing a Wallace anastomosis. This consists of constructing a Wallace plate on the posterior aspects of the distal ureters, and then anastomosing them onto the proximal end of the ureter of a ileal conduit, which would be harvested from terminal ileum, going approximately 20 centimeters from the ileocecal valve, and using a 20 to 30 centimeter length of bowel.
Is there any role for neobladder reconstruction?
So a neobladder, an orthotopic neobladder could be offered to patients if they are very much resistant to having an ileal conduit, and if they feel that it would psychologically be too much for them to live with a conduit. However, there are contraindications to this. For example, if there is invasive urethral disease or if there is extensive CIS. Other contraindications include an inability to perform ISC, because this is required post-op, and also if the patient has a GFR of less than 60, if they have urethral sphincter incontinence causing incontinence, and also if they've had preoperative radiotherapy or the presence of inflammatory bowel disease.
Why in a patient with EGFR less than 60, neobladder reconstruction is contraindicated?
So this would be because one of the potential complications, or one of the potential late complications arising from neobladder construction would be renal failure due to the associated metabolic effects and risk of recurrent UTIs.
Okay, so what are the methods by which neobladder can be reconstructed?
So I'm aware of the Studer technique, which uses harvests terminal ileum approximately 30 centimeters from the ileocecal valve, and a 60 centimeter segment is harvested. The distal 40 centimeters is detubularized and anastomosed onto the urethra, whereas the proximal 10 centimeters is formed into a tubular portion, and this is where the ureters are then anastomosed onto, again using a Wallace plate technique.
Okay, what are the long-term complications of neobladder?
The long-term complications include a risk of malignancy at the ureterointestinal anastomosis. There is a long-term risk of renal failure. There's a long-term risk of metabolic complications, including B12 and folate deficiency if terminal ileum was used, a long-term acid-base electrolyte imbalances, bone resorption, and there are also specific urological complications, including a intestinal anastomotic stricture, formation of stones, mucus production needing ISC, and recurrent UTIs.
Okay. What are the methods by which radical cystectomy could be performed?
So this can be performed using an open approach, laparoscopic, or a robotic assisted approach.
What is the evidence behind robotic assisted?
I'm not aware of the authors, but the robotic assisted approach has been associated with a significantly lesser blood transfusion rate and bleeding, and a shorter length of stay in hospital. However, in terms of the oncological and longer-term metabolic outcomes, there's been no significant difference compared to the open approach.
What is your plan for the lymph node dissection?
So my plan will be to perform a standard bilateral pelvic lymphadenectomy, but this will be taking lymph nodes from the true pelvis, which will be from the obturator, internal iliac, external iliac, and the presacral groups bilaterally.
Okay. Is there any levels of lymph node dissection depending upon the tumor?
So I'm not aware of a dissection depending on the tumor itself, but I'm aware that the levels of further extended pelvic lymph node dissection would go up to the bifurcation of the aorta, and a super extended pelvic lymph node dissection would go up to the level of the inferior mesenteric artery.
Okay, well done. We will complete there. Again, nice flow, no concerns, clear answers. I will say absolute complete full mark, so you have nothing to really concentrate or to improve on. The only few things what I will advise is in the pre-op preparation, apart from the stoma nurse, you can involve the enhanced recovery protocol nurse. Remember that for both radical nephrectomy and radical cystectomies, and also sometimes like nail cancer or any other radical surgeries like retroperitoneal lymph nodes for testicular cancers, etc. And when you are giving the exit strategy after radical cystectomy, when you're discussing radical cystectomy itself, bring the options of open laparoscope versus robotic assisted, and in my practice I do open. Nothing wrong in it. You can say in my practice I will do robotic assisted radical cystectomy with open conversion for ileal diversion or neobladder reconstruction. So when discussing the surgery itself, you can bring yourself the three methods available and what you normally perform, so that the examiner will just keep in that level. But for theory's sake, he or she may ask you about the robotic assisted, what is the advantage. And similarly, the ileal conduit versus neobladder, instead of me asking you what is neobladder, you can say there are two options of reconstructing the ureter, ileal conduit and neobladder. In my practice, I will do ileal conduit or the other one. So you can choose whichever you want, and the examiner may be happy to take it through what you are doing. But just for theory's sake, they may say, okay, I know you are not doing neobladder. What are the methods of reconstruction? What are the long-term effects, etc.? They can ask theoretically. Otherwise, I think you're absolutely fine. We try to do a kind of covering all the scenarios. So started from visible hematuria, evaluation, non-muscle invasive bladder tumor, muscle invasive bladder tumor, including chemotherapy. The only few things which we haven't touched is the radiotherapy, which mostly, I will say, 90% won't be asked because they want to test you in the urology rather than the radical radiotherapy, which is not also that common in bladder compared to the prostates. I'm happy with your progression. Very good. Well done. Any questions you have before we complete?
No, I don't think so. I think the main thing will be probably the nerves on the day, but I'm sure that'll settle by the time I get into the swing of the after the first few stations.
See, in exam, at any point you will talk only like 10 plus 10, 20 minutes in a stretch. I am purposefully doing as much as possible 3 10-minute sessions so that your capacity or the vital capacity and the mind flow is now easily fixed for 30 minutes. So doing 20 minutes will be more easier. So it's like we are training you for a good 20-meter dash, but in the actual test you are tested only for 100-meter dash. So you will feel more easier actually in the exam compared to what you're doing with us.
Yeah.
Good. Well done. So if there are no further questions, have a nice rest of the day. I will keep in touch with you with maybe one slot for tomorrow. If you are able to take it up, that's fine. But be flexible. The choice is yours.
All right.
Good. Have a nice rest of the day. Bye.
You too. Bye-bye.